Thank you so much. This has been such a fun day so far. So thank you, Millennium. So I run the healthcare and pharmaceutical management program at Columbia Business School. So we are training the future leaders for healthcare in the United States and globally. So thank you. And so it's my privilege really to talk tonight with Dr. Vindell Washington, who I got to know over the past couple of weeks. And what struck me about Dr. Washington is what an interesting background he has. It spans multiple sectors along the healthcare ecosystem: provider, health system, tech, government, and payer. So, Vindell, you were trained as an emergency medicine physician, right? Yes. You ran a large physician group in North Carolina. You served as CMIO of Franciscan Missionaries of Our Lady Health System in Baton Rouge, Louisiana. And then you went on to become the National Coordinator for Health IT at HHS, which is one of the biggest jobs in, yes, one of the biggest jobs you can have. And then you've now been the Chief Medical Officer of Blue Cross Blue Shield Louisiana for about a year. So I wanted to start with your time at ONC, right, which for those of us in the private sector who don't get a lot of time understanding what goes on in government, hard to know, right? So what drew you to government, and what was ONC like?
Thanks, Bunny, for that. I kind of have to start my discussion about my time at HHS with a little bit of a story, because there's a lesson to be learned from it, I think. So I was a CMIO at the health system in Baton Rouge, and I had done my usual, which was to complain about the way the world works and the things that I thought should be changed. And so I ended up going to see our senator, Senator Cassidy, to give him a piece of my mind about this whole meaningful use thing. And lo and behold, about a month or two later, he had a Senate Help Committee testimony that he required of or asked me to participate in. So I got up there and I wandered up and I told him how things should work and what the real world should be like, et cetera, et cetera. And so the lesson I learned was, don't really complain about something without the right amount of understanding or empathy, because that problem may be your problem pretty soon. And about somewhere around 6 or 8 months later, I went to work for Secretary Burwell with the Obama administration in health IT. But really the nidus was just thinking about things that I had experienced from the beginning of the Meaningful Use program in 2009, and making some suggestions. And so it was a little bit of serendipity. I can't tell you, if you'd asked me before that, how do you apply to be the national coordinator, I had no clue. And had no idea how White House personnel office worked or any of those things. So a bit of serendipity, but it was a great experience for me, and I enjoyed my time.
Okay, so great, but what did you do, there? Because a lot happens there that affects all of us in this room. So.
Yeah. So look, the job description is really around setting the tone for health IT policy for the country. So it sounds as big and broad as it is, and so the main part of the certification activity I did was to talk to the 800 EMR vendors across the country and set standards for how they work and practice. But we were also responsible for all the components of health IT that went across the federal government. So that includes the Indian Health Service, it includes giving recommendations to the VA and DoD. And my most sort of satisfying experience on it was to really revamp the way the Meaningful Use program worked. Phase 3 or stage 3 of Meaningful Use was really going to be another series of checklists, about 34, by the way. And one of the things I was able to do in collaboration with CMS over that period of time was to change the Meaningful Use program from really just a series of checkboxes to really 5 or 6 mandatory items and have all those mandatory items be about information exchange. And so I leaned in on the interoperability piece of it. And so I would say that was sort of one of my major sort of accomplishments and things I'm most proud of. What we worked hardest on were things like the 21st Century Cures Act, though, where we really tried to say, literally we would get complaints from providers about their EMR systems and they couldn't exchange data and their vendor made them pay X, Y, or Z for the basics. And the 21st Century Cures Act really was the first bit of legislation that we worked on across both sides of the aisle. We were sort of discussing kind of the Senate Health Committee at my table for dinner, and one of our biggest proponents for that was Senator Alexander and pushing that through so that there's real teeth behind bad actors in the health IT space. And so it was really a rewarding time. And if I can, I'll share one other part of what I think we did most effectively, and that was this sort of construct of delivery system reform. So most of what we did across the agency was to try to work for changing the way that care was delivered, physicians were paid, and the infrastructure that supported it. And so all of the bundles that came out, all the CMMI initiatives, et cetera, that we pushed for really hard in the last years of the administration were aimed at trying to change the alignment and the relationship between payers in this ecosystem and the providers who were sort of subject to it.
Well, I know you and I, and today also, we've talked a lot about alignment of incentives, right?
Yes.
And how that impacts healthcare.
Yeah.
So so you were at ONC, so
Yeah.
what drew you to the payer side? Why did you go to that side?
Yeah. Well, can we go back to serendipity again? I think part of one of the things I did realize when I was at HHS, and this was my sort of bit of my epiphany, was that you really can't change some of the fundamental components of the healthcare delivery system without changing the way healthcare is paid for. And so, my anecdote is when I was on the provider side, I had a supportive CEO, and at that time I was also responsible for our medical group. So I had 500 physicians across the state. I had a supportive CEO. We gave a lot of lip service to value-based care delivery. But the fact of the matter is, when the 10-year capital plan came up and my data warehouse or my care and case and disease management strategies came up against the 100-bed tower that was going to get built or the ambulatory surgery center, I always lost. And I lost because at the end of the day, the capital structure and the alignment was not appropriate to allow for that investment to be made. That was one of the things that sort of struck me. And so I noticed when we were working on MACRA and the MIPS program at CMS with Andy Slavitt and that crew, and we would talk to CEOs of health systems across the country, they were completely tuned in about what we were going to do. And we would sort of have an interesting dynamic where folks would really rail when the cameras were around, and then afterwards we'd sort of get a pat on the back to say, really push hard on this value thing, because if CMS doesn't take the lead on these bundles, et cetera, we won't get there. And so my draw on the provider side was to say, to the payer side was to say, I could have a role like that in Louisiana, a place that really needs some disruption, if I could be on the side of the largest payer in the state, the largest private payer in the state, and align some of the incentives so that the guy that's in my old job at the health system across town has a chance when the capital budgets are made to really change the way care is delivered in the state.
Wow. So those of us who are not in this day to day, that's pretty amazing, right? That you would think that. All right. So now that you're at Blue Cross Blue Shield LA, what are some of the big issues that you're really excited about?
Well, I'll start with the problems. Louisiana is a pretty poor state. Louisiana has pretty bad health outcomes. If you look at our social determinants across our state, it's really difficult. One of the other sort of not so happy topics that I was talking with some friends about today was the fact that we have the 4th highest rate of colon cancer deaths in the country. And so we have a lot of problems in that space. And one of the first things I noticed and sort of leaned in on was, how do I work in a system that has limited resources and provide those resources where they're needed and to have a real outcome for the citizens of the state. So one of the things I'm most excited about is the work that we're doing from a data analytics perspective. And there's a reason for the data analytics. I would say that we had good programs for disease management, but when I first joined the plan a year ago, we kind of spread them around like peanut butter. I mean, essentially, if you had diabetes, you got a pre-visit call, you had someone check on your medications, you had some encouragement from our diabetic dietitian, but we really had no capacity to treat person A any different than person B, even if we knew they had different needs. And so one of the things I'm most excited about is our ability to now use artificial intelligence, and in particular machine learning, to say, if we're going to try something new and innovative, where should we apply those resources in a resource-constrained environment? Mm-hmm. And so what we do now is we use a lot of voice-to-text work to change our call center calls and my nurse case manager calls into data. We take claims data. We take clinical data from EMRs. We have a pretty robust exchange that's in place with that. And then what we come out with is a series of folks to whom we lean in pretty heavily to try new interventions. And so we do things like we have some home health resources we bring to bear. I think in one of the sessions earlier, people were talking about using Lyft or Uber for folks to help them get to appointments. But the fact of the matter is we can't do home blood pressure monitoring or Lyft or Uber for every single diabetic on our panel. What we're trying to do is to concentrate efforts where the data and analytics say they're going to be best received and that they're most needed. And then for the bottom side of the pyramid, we're actually pivoting away from a lot of touches. I'll share one anecdote on this. So as one of the early conversations I had as a new leader of the health group, I went to one of my primary care docs, this is before I got to government, and I said, so you have your diabetics and you see them 4 times a year. And I said, well, is there any literature on that? Why do you see them 4 times a year? He says, well, Blue Cross pays for them to be seen 4 times a year. And so from my perspective, if you're at the bottom side of that pyramid, I'm convinced that there are a lot of chronic diseases that can either be virtually managed with an annual visit or an every other year visit, such that the deployment of resources across our plan will be the exact inversion of the pyramid today, and we will have no specific treatment that is done for every single patient, because we're going to recognize there's a level of precision that we can bring to the table in our analysis of what's needed in the market. And that's one of the things I'm sort of most excited about. We have a test and learn strategy that allows us to deploy analytics in a way that allows us to deliver the right care for members across the state. And I think that's really going to help us move the ball forward.
So vis-a-vis analytics, obviously that's a huge area.
Yes.
How are you doing that? Is it an internal thing or external? How are you
Yeah.
doing that?
In the whole buy versus make scenario, I spent most of my career on the buy side because when I was a CMIO at the health system, if I had just a dime for every time an analyst walked in and said I could build that, I'd be a rich person because half of them didn't work out. But we actually were lucky enough to get some talent in place. And the one thing I will say so the short answer is we are doing it internally. But the one thing I will tell you that I think is different in this marketplace is that when you're talking about some of the basic machine learning tools, it is not the rocket science it was a decade ago or 15 years ago. There are a lot of off-the-shelf strategies that you can deploy, or combination cloud and internal resource strategies that doesn't require a plan of our size in Louisiana to sort of mine the best talent in the world to execute on these kinds of plans and activities. So we do much of the machine learning internal. Most of the voice to text stuff is from Alphabet or some Google sources. We do some offshore work. We've got that support through some contracting with Deloitte and some analysis that helped us find the right companies to do that. We're convinced for this level of activity that we're able to do much of that machine learning and AI internally. And then when it comes to things that are more robust, I suspect we'll revisit that scenario. But we think that it's possible for plans and even health systems of certain size to do some of this analytic work on their own.
So AI, like you can't have a healthcare conference, right, without talking about AI.
That's my job to bring it up.
Right,
Yeah.
absolutely. You know, of course, it's the new thing. AI is the thing right now, but there are some limitations, right? I mean, it's not everything. So what are some of the challenges that are inherent with AI today?
Well, I talk with my team about this a lot. So one concrete example, and I'll use my health plan and my job. If you were to say, I would want to use machine learning to say who is the person who should sit in as the CMO at Blue Cross Blue Shield of Louisiana, a black male doctor who came from the provider side would not fit that machine learning algorithm, okay? So it's really not, there's not magic in the machine learning algorithm itself. You have to bring some sense of what you're studying to the table, because in effect, what machine learning does in the abstract is to say, what happened in the past, and can I use that to predict what's going to happen in the future? And so there are lots of pitfalls you can use. Now, one of the things we looked at, for example, is the use of some tools around self-management in the New Orleans market. And you really have to be careful about deciding whether or not someone is too old, too poor, too young to use a certain set of tools just because they haven't used them in the past. But I will tell you that in a situation like ours where there are limited resources and you have good clinical insight that you want to deploy, but you have a complex problem, I think that's one of the areas that machine learning can be completely helpful. As we say, the machine learning can sort of offer you some suggestions, but then you have to use your special expertise to decide whether or not those things really make sense, or even from a moral perspective should be pursued. And so I think your point about pursuing some of the AI and machine learning aspects really at this point require you to take a balanced approach.
Right. So I know today technology obviously has been a big topic.
Yeah.
With you at BCBS LA, what other technologies are you employing to help with your, patients, like televisits?
Yeah. Yeah, we have a pretty broad approach, I would say. One of the things I actually took with me from Baton Rouge to DC was a certain approach, which is to say that a lot of this is the real magic is to try to tell the tool from the toy. Mm-hmm. And what I would say is that we have a propensity to deploy technology, but I would say really only where we think that there's a real problem to be solved, and then really try not to do technology for technology's sake. And so I'll give you a couple of specific examples. So we know that in a couple of parishes in the Lafayette area, which is about a couple hours west of New Orleans, we literally counted the number of diabetic educators, and there were 5, and 3 of which were assigned to the federally health qualified folks, health centers there. So there's literally not enough resource there. And we felt that that was like the perfect spot for us to deploy some telemedicine activity. So we used a vendor to help us extend our reach to that market. We think that that's a smart use of technology. On the other hand, I think we're really careful about telemedicine sort of in and of itself or on its own standalone merit. We think that there's some smart places to deploy it, and we have to be good about that. The other one I want to share with you that I think is particularly interesting to me is this idea about how you manage people who are doing reasonably well, and can technology play a role in that? And so one of the other programs that I'm excited about is we're doing a program in a collaboration with the health system in New Orleans where we do blood pressure management with blood pressure monitoring at home tools, and a pharmacy team that actually adjusts blood pressure medicines. And so for us, what we found is if you just walk into a patient room and you say, you have high blood pressure, it's an important disease, take your medicine, in our experience, about 3 in 10 people will take their medicine and things will be all fine. And there may be another 3 or 4 that you get to the table if you put robust disease management, if you align with physicians, if you sort of work really hard at it. But you still end up with only 7 or 8 out of 10. So what we're trying to do is to figure out, is there a way to use some technology and some smarter strategies to get to that 9th and 10th person out of 10 to do this? And so those are the kinds of areas that we are leaning pretty heavily in from a technology perspective that we think either extends our reach or provides services in ways that we hadn't thought about before. And in particular, we're interested in doing those things that have partnerships with providers in the community. And we think that that's a key aspect of this technology delivery.
So the other thing we can't not talk about, because it's, healthcare, is blockchain. So who here understands blockchain? Raise your hand. Yeah, great. All right, so absolutely none of us understand blockchain. However, it is important to understand blockchain. So we're not gonna give you a tutorial tonight about blockchain, but
Thank goodness.
we will not. However, if you don't you gotta kind of know a little bit about it. So how do you think it will be employed in the payer community or in healthcare generally?
So I think that we've talked about this a little bit in our earlier conversations, and I think there's going to be a role for blockchain. I'll tell you one of the things that we did when I was national coordinator is we actually had a challenge, and we had about 50 folks across the country write us their ideas about ways that blockchain could be used in healthcare. And really innovative ideas and thoughts. I think the real enticing portion of how blockchain works that can be used is really this idea that you can have nodes in the system with information that can exchange information securely, node to node. And the reason I think it's important is that some of the barriers to information exchange are that these large entities that have information are quite concerned that because they are custodians of that information for some period of time, they're going to be at significant risk if that information is hacked, shared in an untoward way, et cetera. So to me, one of the promises of blockchain is really around the privacy and security aspects of it. And so I'm not smart enough to predict for you exactly when and how it will be deployed. I think that there is a there when we talk about blockchain. And I think it's an exciting thing. I think most of us really heard most about blockchain when it came down to Bitcoin or for some drug kingpin exchanging money in some secure fashion. So it sort of came to us in this sort of nefarious way. Right. But and I actually still think it's there. But if you go to the ONC website, there's some really interesting ideas that people across the country put on the table about ways that you can use this kind of technology to really free data and to allow the empowerment of individuals in this care delivery scenario to exchange information in a secure fashion with those who need it. And so at a time and place of your choosing, you can exchange information. I think that's one of the critical aspects that I'm excited about.
Yes, so I would say about blockchain and all technologies, right, like we all think about cryptocurrency or whatever, but the reality is it is actually a pretty interesting technology that will inform a lot. So if you don't understand the basics, do a webinar, something, because it's actually important to understand that. Yeah. So want to change topics a little bit. I mean, who here in the room doesn't care about drug pricing? Yeah, right. So exactly. So obviously, drug pricing is a major concern for many of you, and in particular, I think oncology prices, right? In terms of what we're paying for. So how's your plan addressing the drug pricing issue?
Yeah, I have to be careful about this topic for a couple of reasons. Number one, that it's probably the folks in the room, your biological clock is somewhere around midnight or so if you came from the
Oh,
East
right.
Coast, so I have
Yeah.
to be careful on this
Right.
piece.
We can, yeah.
But I will sort of narrow down to a couple of high
Yes.
points on this. Our plan, we've had a pretty light touch when it comes to pharma. But I will tell you that the platform is sort of more than just burning these days. And I think the people who are interested in it now include a bunch of folks, including our providers, who, frankly, heretofore were pretty much sort of asleep on this whole issue. One of the things that strikes me, and we looked at our claims dollars, and I think we're probably similar to many in the country, but in 2009, we paid our prescription drug costs were about 19 cents out of the premium dollar. And in 2016, our prescription drug costs were somewhere around 26 cents of the premium dollar. And so it's not like this drug pharma issue is one that has been going on forever or that we have a 30-year history of this issue. This is a relatively quick and sharp increase in over-the-counter drug costs. And this is before CAR T therapy, and maybe in a little bit of that you have some Hep C drugs, et cetera. But literally, this is sort of a change before some of these even more expensive things are coming down the pipeline. And for us, last year was the first year that we actually paid more of the premium dollar for prescription drugs than we did to physicians. And so when I've been having my sessions with doctors, it's one of the things that really gets people's attention. And so we're going at it at a number of different ways. We're leaning in on just following the actual trends from a drug perspective, because in our experience, it's not really the new, exciting breakthrough discovery. It's some companies saying, look, if I put this proton pump inhibitor and this non-steroidal together, even though it costs $41 a month over the counter, I can have a prescription for it for $2,300 a month, and I can give my patient a coupon, and everything will be great. I mean, for us, a lot of the increase has been, our pharmacy lead calls them pharma shenanigans. And so we've leaned in on that. We've also tried to, again, partner with physicians and have more transparency. So we have a lot of work from an IT perspective on trying to do some transparency efforts with providers. I remember the first time I talked to a group of orthopedic doctors who were handing out coupons for this, the Duexis of Removo drugs or these combination drugs. And the look on their faces, it was just pretty clear. They had no clue what their actions had relative to the negotiations for their next contract or the overall cost to the plan. And so what we're trying to do is to have that information come closer and closer to the physician at the time of prescribing. Working with our PBM and others to do some data transparency efforts. And then we're also trying to make it clear to patients. I will tell you, I think we're behind in that, I think the data we give patients by and large is pretty poor. We have a pretty complicated prescription regimen where you have tiered pharmaceuticals for patients, and what we usually tell them is that if you go to Walgreens versus Walmart, you may have a savings. I think for it really to be a tool that works, it has to have a lot higher degree of accuracy in the information that we give patients. But the short answer is we are particularly worried. We think that is something new, and so I fundamentally reject that this pharmaceutical prescription drug piece is a new horizon activity. And I think the reason that we're leaning in so hard is that we think that over the next period of time, when we're really talking about new oncological drugs, or we're talking about new TNF drugs, and we're talking about really new breakthrough things, it's only going to worsen the intensity of this pressure that's on the entirety of the health system.
So before I do Q&A, so you have had an amazing career, right? Like, you have done so many impressive things across the ecosystem. And all of us in this room have been in healthcare for a long time, right? Like, we've seen it all.
Yeah.
What makes you optimistic for the future?
The short answer is actually, actually, I'm optimistic.
I think we all, we all are.
I'm optimistic. So I'll share one thought that I'm slightly reluctant to share, but it's what I believe. I think that we have a series of steps that we needed to take to move forward in healthcare. And although it resonates with me when people talk about getting back to practice that is a more patient-centered and concentrates more on the doctor-patient relationship. But here's one thing that I know. A lot of the things that we talk about in terms of precision medicine, population health management, all those things, there's no way those things could have happened in the healthcare system that we had 20 or 25 years ago. I think it really is a move to go forward. And so I look at some of the work that we did at ONC. I look at the fact now that most of the health system is wired. I think it's a good step on the way forward. I've shared with a few folks that the four of us who were the national coordinators during the Obama administration, we put out an article in New England Journal. We basically said a few things. One of them was, we're happy that we are wired. We feel bad that a lot of that came on the backs of providers, physicians in general, because we think the design leaves a little bit to be desired. But we also feel like it was the fundamental building block to allow us to move forward on a lot of the things that we want to do. And the last thing I'll share about that is I think that if you talk about the stakeholders that exist in the community, one of the reasons that EMRs do whatever they do or what they don't do is that there are a lot of stakeholders at that table. And I'll tell you one group that I have had the opportunity to speak with across the country that are pretty darn happy that things have gone the way they've gone, and that's CFOs of your health systems and IDNs. Because if there's one thing that EMRs did not miss a beat on is making sure that your rev cycle stayed the way that it was expected to stay over that period of time. What I'm hopeful of, and I actually see a lot of evidence of that when I talk to my friends in Silicon Valley and some of the startups, is that now people are really leaning in. There are a lot of really exciting companies that are doing both some machine learning and voice recognition, clinical decision support to actually make the experience much better for both the provider and the patient that are doing this work. And I'm actually encouraged by a lot of the work that I see among our folks in the Blues plans and other payer organizations where this idea of partnership has really come to the forefront. I've heard more discussions about shared arrangements, products that people go to the market with, consolidations that really make me think that we're on the cusp of some good things.
All right. So we have time for some Q&A. So let's do it. So can you just say who you are, where you're from, like your plan?
Karen Babas from Molina Healthcare. What kind of data would you share with your membership, with your patients, if you had carte blanche to share whatever?
Yeah, so if you put me on a spectrum of open notes and sort of everything's available for everyone, versus there's some things we should protect people from. I mean, my bias is way on this side of the ledger, in that we should share information with patients. The one thing that really gets me anxious when I talk to some folks about their business strategies is that if I talk to a company and I feel like the core of their business strategy is that we collect information that's hard to collect, and then we want to sell you the information we collected, that really gets me anxious. And so, the Fed started it early with the Blue Button Initiative with some of the Medicare patients. Now Brennan at CMS and some others tried to push that further. I think that's actually a good thing for the system to have more information available. I know that it needs to be secure. I know that people have privacy rights that need to be respected, but I think as a plan, this idea of being able to provide information. One of the things I was particularly happy about at HHS is we did a interoperable med list challenge to the country. And that was really all about saying, it doesn't matter who prescribed your medicine. I was pushing for a system where a patient would be able to take their smartphone, have an up-to-date list of their medications, whether 2 came from Dr. A and 3 from Dr. B, and 1 was on Epic and 1 was on Cerner, because I do believe that that's the right place for us to land. I think folks should make their cash. Again, this is the world according to Vindell. But I think folks should make their cash based on the innovations and IP they put together, from the user interface, the analytics, the predictions they can make, the newness of the model they present. But it really irks me a bit when people really have the core of their business model be, I have a hemoglobin A1C and you don't, and I would like a per member per month or a transactional fee for me to share that with you. Because first of all, in my heart of hearts, I think that belongs, at least in part, to the patient whose blood you took to get the hemoglobin A1C. So that's my bias.
And those desserts are going to like make the hemoglobin.
Speaking of hemoglobin A1C,
Yeah.
here comes your dessert. Yeah.
Hi, Sheila Bodick from Cigna HealthSpring. As you talk about these different initiatives, we're continually functioning on predictive analytics.
Yeah.
And we leave that particular piece to the wayside. But when we look at predictive analytics, where do you see the major downfalls of the misuse of data?
Well, I think, one of the broad themes I was trying to underscore before is that the analytics themselves, the way that they're structured is that they look at the past and they make guesses at the future as to how A ties to B that ties to C. And my fear is that, like a lot of the technologies, people become blind to the output and don't realize that there's often more work to be done. The joke is about the man who's driving his car and he ends up in the lake and he says, well, my voice-activated Garmin told me to drive this way, and didn't take his eyes up off the road. So I think that's one of the things, even in our small efforts in the predictive analytics space, sometimes we spend a lot of time looking at the obvious, or we sort of overinterpret. One of the things that we pulled down early is we looked at our risk of hospitalization model to give to our care managers, and 6 of the first 10 predictors that came out were things that we either could do nothing about or that just weren't helpful for us in knowing what to do next. And so I would say blindly following output from an analytics model without really bringing your own expertise, your own clinical expertise, your own common sense to the table is one of the areas I've seen people stumble with early in the journey.
Any more questions? No? All right, well, I think it's dessert time.
It's dessert time.
It's dessert time. Well, thank you so much, Vindell.
Thank you. I appreciate
Thank you.
it.